tonight is chapter 17, cardiovascular emergencies is what we'll be going over. We're going to kick it off with our standard competencies. So a big part of this is going to be the pathophysiology, which you know that I like. It applies the fundamental knowledge of pathophysiology of respiration and perfusion to patient assessment and management, which we'll definitely be going over. All right, for the medicine, applies fundamental knowledge to provide basic emergency care and transportation based on assessment findings for an acutely adult or acutely ill patient. All right, so cardiovascular, what we'll be going over tonight. So we'll be going over some of the anatomy, signs, symptoms, and management of chest pain, cardiac arrest. We'll also be going over acute coronary syndrome, or ACS. Angina pectoris, we'll talk about what that is. If you remember your medical terminology, you could probably break that down right now. Myocardial infarction, if you have been keeping up to date with your medical terminology, you could break that down as well to figure out what that is. Just remember, myo means muscle, right? All right, we'll also be covering aortic aneurysm and dissection. What I always talk about for aortic aneurysm and dissection is, or what we call a AAA. Also, we'll talk about that as well. All right, some more thromboembolism. If you remember from what we talked about last chapter, we talked a little bit about embolism. This just goes even further into it. We touched base on a little bit of heart failure, hypertensive emergencies. We'll be touching base with that as well. All right, so introduction. So as you can see here, cardiovascular disease accounts for about 1 of every 3 deaths. That is a lot. That is a lot. So EMS can reduce the rates by providing some of the following services that you see here on this slide. Encouragement of people to follow a healthy lifestyle, early access to medical care, more CPR training of lay people. They even have lay people CPR, hands-only CPR. They have the mannequin set up in the mall in a box. I've seen them. It's pretty amazing. Also, increased use of evolving technology in dispatch and cardiac arrest response as well. So more honing in on the EMDs, or emergency medical dispatchers, so where they can actually tell you what to do or assist you verbally via phone on what you need to do next. All right. Also some of the other stuff that we can do to reduce deaths: public access to defibrillation devices, recognition of the need for ALS, and then the use of cardiac specialty centers when they are available. So public access to defibrillation devices, that's absolutely huge. Now they have different apps that, like Pulse Point. If you ever have an opportunity to look up Pulse Point, then you'll really get to see what people are actively trying to do to be able to get CPR to anybody anywhere and defibrillation to anybody anywhere. It's a pretty amazing app that they have built there. And I wish that more cities would use it. I wish that more rural counties would use, or more rural areas would use it as well. Also, the recognition of the need for ALS, so advanced life support. It's very important as an EMT that through your assessment and through your critical thinking skills, that you can recognize when you need to call that resource for a rendezvous, or for what have you, for a pickup, for a meetup, for ALS, to be able to receive that advanced life support. Being able to recognize that and recognize that early is really what's going to make a difference between a patient, living and dying, improving or declining, or what have you. That's going to make the difference. So being able, through your advanced assessment skills, you'll be able to make these determinations fairly easy. All right, so on to the anatomy and physiology. So the heart's job is to pump blood to the to supply oxygen-enriched red blood cells to the tissues of the body. So the heart is divided down the middle into left and right sides. So each with an upper chamber. The upper chamber is what we call the atrium, to receive incoming blood, and a lower chamber called the ventricle to pump outgoing blood. So the atrium receives, the ventricle pumps out. Atrium incoming, ventricle outgoing. All right, on the next page, we'll see a little bit of what we're talking about. So in your book, chapter 17, first figure there, you'll see the four chambers of the chambered muscle that pumps blood to all the parts of the body. So this is going to illustrate the heart. Knowing how this heart pumps and knowing what the process is for this is very important for you as an EMT. It's going to be even more important whenever you start to advance and you take EKG classes or what have you. That's really going to help. But knowing how this works and what can go wrong right now as an EMT is going to be very important. The pathophysiology is going to be very important for this. All right. So blood leaves each of the four chambers of the heart through one-way valves. All right. It leaves each of the four chambers through one-way valves, which is going to keep the blood moving through the circulatory system in the proper direction. So the aorta, the body's main artery, receives blood ejected from the left ventricle, and it delivers it to all the other arteries that supply the body's tissues. All right, so on this figure here, this slide is going to illustrate how the blood circulates through the heart. If you look at A, so the right side of the heart receives oxygen poor blood from the venous circulation. And then in B, right above, right here, the left side of the heart receives oxygen-rich blood from the lungs through the pulmonary veins. All right. So the right side receives what? Can anybody tell me?
Rich oxygenated blood.
It's going to, nope, oxygen poor. The right side receives oxygen poor. Okay. And then, yep, oxygen deficient. And then the left side is oxygen rich. Okay, it's coming from the lungs, right? So,
okay. Looking at it wrong, my fault.
No, that's all right. So here's the thing. Which side is bigger? The right or the left side? Okay. Can anybody tell me why it's bigger? Why would the left side need to be bigger? All right, we'll answer it. So both sides do the pumping. Both sides pump. All of the heart pumps, all right? But the left side does something special. All right, so this is why all of it pumps here. Well, let me back up. Sorry. So the left side is going to pump where? To the body. And there's a lot more body than there is lungs, right? So it's trying to get all that oxygen rich blood out, right? It's trying to get it out. So it's got to be much larger. Okay? All right. So the heart's electrical system, it controls heart rate and it coordinates the work of the atria and the ventricles. So the heart generates its own electricity. It's the only muscle. It's the only muscle that creates its own electricity without any other outside. Without anything from the outside that's creating it for them, or any pulse or anything else. It creates its own electricity. All right. So the heart, it generates its own electrical impulse starting at the sinus node. All right, the sinus node. The impulse then passes from the atria to the ventricles. Atria to ventricles. All right, so a term that you'll see here is automaticity. So automaticity allows spontaneous contraction without a stimulus from a nerve source. As long as impulses come from the sinoatrial node, SA, right? SA node, the other myocardial cells will contract when the impulse reaches them. So if no pulse arrives, then the other myocardial cells are capable of creating their own impulses and stimulating a contraction. Right? They make their own electricity, right? All right, so you can see this figure here. It illustrates the electrical conduction systems of the heart. So what tool do you think we use, all right, that's going to show how well this electricity is working? Mostly we'll use some of the tool once you get further on, once you decide to go to EMT and paramedic. Yep, EKG. That's right, your ECG, EKG. That is what's really going to read. So those lines that go up and down, that's what it's reading, that electrical impulse from there. So if you look at it, if you do a 12 lead, then the 12 lead, there's a certain way that we have to put it on. And always remember this. You'll have paramedics that'll say, oh, just put it on there any certain way. Whoop, nope, that's not what I meant to do. You'll have paramedics that'll tell you, oh, just put it on. What did I do to myself? There we go. They'll say, you just put them on anyway. No, incorrect. Absolutely not correct. No. So it's got to be able to go and look around the heart. That's basically what that does. So what it does, it creates certain points, and it's going to cause, it does what we call a pie. So it's going to be 12 slices of pie at 30 degrees apiece, all around the heart, and that's how we read an ECG. So it is very important that we have the correct placement of the electrodes on the person, to include, if we want to get a true ECG, to include having it on the extremities, having the basic, or your 3-lead or 4-lead, just depending on what you call them, but your 3-lead on the actual limbs, not on the trunk, not on the shoulders, but on the actual limbs themselves. It's going to create what's called Einthoven's triangle. We could get way further into that. We will not, but I'm just saying it's very important. If you want to read more about it, feel free to look it up. It's going to help you better understand how this works. You may think it's a little ahead, but if you get on an ambulance, trust me, you're going to see this. You're going to see a monitor at some point, and you're going to get a crash course on it while you're on the ambulance. It's just best to take a look before you get in there. This is the kind of stuff that excites me. I love ECGs. I love ECG Myron 12 lead classes. I like those classes. A lot of fun. All right. So I'm glad you asked that. So Devontae asked, if it's not conducted, will the muscle die? All right. So this is what happens. So it's not so much that the muscle dies because of that. Yes, that does happen. If the electrical gets messed up, then it can't pump. It's not going to work, or it'll work incorrectly. Sometimes it misfires. So when we talk about fibrillation, that's a misfire. Okay. Or we have delays depending on if something's wrong with that muscle itself. What also depends on, just like with anything, electricity follows the path of least resistance. All right, so knowing that if a heart muscle is dead due to not getting oxygen, due to not getting blood flow to get that oxygen into the muscle, and it starts to die, don't you think that's going to increase the resistance of that muscle, it dying? Yes. And when it increases the resistance, it's going to mess with the electricity. It's going to increase the resistance on the electricity to get to that muscle. So it's not going to be able to do the contractions or keep up like it's supposed to. All right, so you'll start to see those issues on your ECG. All right, so you'll start to see that play out on your ECG as well. And that's when you start to see that it's not conducting correctly. It's not conducting at the right electrical impulse level. It's not, or it may not be conducting at all because of ischemia or injury. And at that point, then it starts to die. The heart starts to die. If it doesn't conduct at all, there is no electricity in it at all, then something major has happened. And now that's why we have to talk about defibrillators, why we have to talk about pacemakers, things like that, because the electrical stops working correctly. And when that happens, we have to install that pacemaker or that defibrillator in somebody's chest, or we have to provide it externally through cardioversion or what have you. Excellent question. All right, so the autonomic nervous system, or ANS, it's going to control involuntary activities to the body. The ANS, or the autonomic nervous system, has two parts, which normally balance one another out. You have the sympathetic nervous system, and then you have the parasympathetic nervous system. All right, the myocardium must have a continuous supply of oxygen and nutrients to pump blood. Cardiac output, and you're going to hear this term throughout your career, cardiac output is increased by increasing the heart rate or stroke volume. All right, so these are all things as you continue your education, you're going to see a lot of these terms again. So in the normal heart, the increased oxygen demand of the myocardium itself is accomplished by increasing the amount of blood that's delivered to the myocardium by dilating the coronary arteries. Dilating means what? To widen, right? So the coronary arteries are blood vessels that supply blood to the heart muscle. They start at the first part of the aorta, just above the aortic valve. The right coronary artery supplies blood to the right atrium and the right ventricle, and in most people, the inferior wall of the left ventricle. The left coronary artery supplies blood to the left atrium and the left ventricle, and divides into two major branches just a short distance from the aorta. All right, so on this photo here, or this illustration here, you can see how the coronary arteries carry the blood supply to the heart. So the arteries supply oxygenated blood to different parts of the body. The right and left carotid arteries supply the head and the brain. All right, carotid, right? The right and left subclavian arteries, okay, supply the upper extremities, subclavian arteries. The brachial artery supplies the arms. The radial and ulnar arteries, okay, supply the lower arms and the hands, okay? Lower arms and hands. The right and left iliac arteries supply the groin, the pelvis, and the legs. So there's a lot there. You can lose a lot of blood there. You also have the right and the left femoral arteries that supply the legs. You can lose a lot of blood with those as well. The anterior and posterior tibial and perineal arteries supply the lower legs and the feet. Then you have the arterioles, and you also have capillaries that are smaller vessels that receive blood from those arteries. So capillaries are 1 cell thick, 1 cell thick. They exchange nutrients and oxygen for waste at the cellular level. They connect arterioles to venules. All right, the venules are the smallest branches of the veins. Now, when you're looking through and you're looking at some of your photos of the heart, the vena cava the vena cava returns oxygen poor blood to the heart itself. The superior vena cava carries blood from the head and the arms back to the right atrium. The inferior vena cava carries blood from the abdomen, kidneys, legs, back, and the legs back to the right atrium. So knowing that it's coming back to the right atrium, is that oxygen rich or oxygen poor blood? Poor. That's right, poor. Fantastic. All right. Now moving on, talking about blood. So blood consists of several types of cells and fluids. So red blood cells carry oxygen and remove carbon dioxide. Right? Red blood cells carry oxygen and remove carbon dioxide. White blood cells fight off infection. Platelets help blood to clot. And then plasma is the fluid that cells float in. So plasma is the fluid that cells float in. That's the clear stuff, right? That's the clear yellowish stuff. Yes, that's correct. Robert Owen puts, so CO2 binds to the red blood cells in the place of O2. Yes. If you remember when I was talking about CO2 poisoning, so in CO2 poisoning, that's what happens. It binds to the hemoglobin, or it binds to the blood cells, all right, and it removes the oxygen. It bombards those blood cells, or it bombards that hemoglobin. And when it bombards the hemoglobin, it's like, get off here, O2. And so it kicks O2 out. However, when you read that patient's SpO2 level, okay, This patient is going to look a little bit red, flushed. They're going to look flushed. You're going to put that SpO2 on them, that monitor, and what is most likely your reading going to be? Can anybody remember that? That's when you have CO2. So it's going to be not just that, it's going to be super high. It could be 100. So it can read 100. But you're looking for other things. Is the patient looking ill? Are they flushed? Are they lethargic? Do they have flu-like symptoms? Is there something else going on? Did you do your O2? You know, you could at that point pull everybody outside. Are there multiple people that are feeling ill? Have they been using an alternate source of power? So when we talk about using something that's fuel, that uses fuel, that could put that back in there. People that put grills inside their homes, people that, you know, all sorts of stuff can cause CO2 poisoning. But it's generally, with CO2 poisoning, your SpO2 is going to be super high. So you're looking at 9,900, most likely 100 is what it'll be reading, 100%. All right, so blood pressure is the force of circulating blood against the artery walls. The systolic, like system, blood pressure is the maximum pressure generated in the arms and legs during the contraction of the left ventricle during the time period known as systole. All right, it's going through the system. It's getting the blood out to the system in systole. And so if the blood is pumping at systole, going through the system, you're going to get your systolic blood pressure at the pump. Okay. And that's going to be your top number, right? Then you have your diastolic. So the diastolic blood pressure is the pressure against the arteries and walls that's left while the ventricle relaxes. So when the ventricle relaxes back, all right, then that's going to be the pressure that's left. And that's going to be your diastolic blood pressure, what's left. So down, diastolic is the way I like to look at that. It'd be the bottom number. All right, moving on. A pulse is left when blood passes through an artery through systole. So when that systole, blood pumping through the system, when it pumps, then when you feel that pump, when you feel that pulse press up against your finger, beat up against your finger, all right, at systole, that's going to be your pulse each time. Your peripheral pulses are felt in the extremities. All right, arms, legs, posterior, you know, so they're talking about like your radial pulse, posterior tibial pulse. All right, your central pulses are felt near the trunk of the body. So like your femoral pulse or your carotid, right? All right, so in this figure, it demonstrates some common pulse points. Take a picture of that and then practice them. All right, cardiac output, like I told you, remember this, it's going to come back up. Here's the definition. So the definition of cardiac output is the volume of blood that passes through the heart in 1 minute. Your cardiac output is the volume of blood, the amount of blood, the total volume of it that passes through the heart in 60 seconds, 1 minute, right? So it's calculated by multiplying the heart rate by the volume of blood ejected with each contraction. So the blood that is ejected with each contraction is called your stroke volume. So as it contracts, that blood that goes That's the stroke volume, right? So in the field, stroke volume can be roughly determined by the heart rate and the strength of a patient's pulse. That's when we talk about bounding, weak and thready, things like that, right? So perfusion describes the constant flow of oxygenated blood to the tissues. All right, that's how we get proper perfusion, because that oxygenation. That's why our cap refill, it works the way it does because it's got proper perfusion, so on and so forth. So this is going to show you good perfusion. What it's going to require is that you have a well-functioning heart. You also have an adequate volume of fluid or blood there as well. Blood vessels must be appropriately constricted to match the volume of blood available. If they're dilated, such as when we're talking about allergic reaction anaphylaxis, then they're dilated up, which means that all that blood is in those peripheral veins, so there's not enough blood in the container, right? Not enough blood going to the heart because it's all in here. All right, so the blood vessels have to be constricted appropriately to match the volume of blood that's available. So if perfusion fails, then what happens is cellular death starts to occur because it's not circulating. And eventually, the patient's going to die if they don't get that fixed. So this is what we're going to do. This is a long one, pathophysiology, and I really want to make sure we get into this and not take a break in the middle of it. So we're going to take a break until on the top of the hour. All right. So here at 6:47, we'll take a break, or we'll come back at 7 o'clock on the dot, and we'll actually get back into this. All right. And we'll start on the pathophys, which is really going to break it down. All right. Pathophysiology of the cardiovascular. All right. So pathophysiology, the heart-related chest pain usually comes from ischemia, okay? So which is going to be decreased blood flow to the heart or an inefficient supply of oxygen and nutrients. The ischemia is what's going to be the injury that occurs because of that. So ischemic heart disease involves a decrease in blood flow to one or more portions of the heart muscle. If the blood flow is not restored, the tissue then becomes, or I'm sorry, if it's not restored, then the tissue dies. It starts to die. So when we're talking about atherosclerosis, so atherosclerosis is a disorder in which calcium and cholesterol build up and form a plaque inside of the walls of blood vessels. So it can cause a complete occlusion, which means a complete blockage, occlusion, good term to learn. So what that does, it creates a complete occlusion or a blockage of a coronary artery and other arteries of the body. So fatty material accumulates as a person ages, resulting in the narrowing of the lumen. The lumen is going to be the middle part, the tube part inside of a vein. Okay, inside of a vein or an artery or anything. That's the lumen. When we're talking about different types of medical supplies, you'll see lumen in there. That's just going to be the tube, in the inner diameter of the tube. So the inner wall of the artery becomes rough and brittle at this point. If a brittle plaque develops a crack for unknown reasons, the ragged edge of the crack activates the blood clotting system. Okay, and this resulting, what it's going to do is going to result in a blood clot that will partially or completely block the lumen of the artery. The lumen. Right? lumen, lumen. Partially blocked lumen, partially blocked lumen. All right, a thromboembolism. So what a thromboembolism is, it's a clot that floats through the blood vessels. If it reaches an area too narrow for it to pass, it stops. And when it stops, it's going to block blood flow at that point. All right, or beyond that point. From that point beyond, it's going to block the blood flow. So any tissues that are downstream from the blood clot will suffer from hypoxia, lack of oxygen, right? Low oxygen, hypoxia, hypoxia. So if too much time passes before the blood flow is resumed, then the tissue will die because of the no perfusion, right? No perfusion distal to that area. So this sequence of events is known as an acute. So this happens in the heart. So when we're talking about all this, this is all happening in the cardiovascular system of the heart, right? So the sequence of events in that point is known as what's called an acute myocardial infarction, or AMI. In other words, it's a classic heart attack. Acute myocardial infarction, AMI, is another term for classic heart attack. So the death of heart muscle can severely diminish the heart's ability to pump. We talked about that, right? It doesn't have the ability to pump because the muscle's not working correctly. The electrical is not going to work correctly. So whatever part is dying is going to be affected, and it's not going to be able to pump appropriately. So in the U.S., coronary artery disease is the #1 cause of death for both men and women. The peak incidence of heart disease is between the ages of about 45 to 64 years of age. But it can also strike an individual ranging from their teens all the way into their 90s. Just depends on what type of issues is going on. So some of the risk factors that place a person at a higher risk for acute myocardial infarction, or AMI, are going to be, and these are very controllable risk factors. Controllable, right? We can control it. So cigarette smoking, high blood pressure, elevated cholesterol level, diabetes, lack of exercise, obesity, some major uncontrollable factors, uncontrollable, can't control it, are going to be your older age, family history, your race, your ethnicity, and male sex. All right, those are uncontrollable factors that up your risk for AMI. So acute coronary syndrome, ACS. So this describes a group of symptoms caused by myocardial ischemia. All right, remember the term ischemia. So this includes temporary myocardial ischemia resulting in angina pectoris. All right, angina pectoris, or a more serious condition, it can be an AMI. All right, pain in the chest pain is going to be angina pectoris, chest pain. And then if it's more serious than just chest pain, it can be an acute myocardial infarction or a heart attack. So angina pectoris occurs when the heart's need for oxygen exceeds the available supply, usually during some sort of physical or emotional stress. All right. That's why a lot of times that people, whenever you have these patients, they were mowing the grass, the chest pain started, they called, and now that you're there, it's not as bad. And that's because they've been resting, they've been back in the air conditioning, they've taken a break, so they're not doing that physical stress or anything like that. All right, or the emotional stress. They break off of it, they start to relax. Now the chest pain doesn't hurt anymore. So it can result from a spasm of an artery, but it's most often a symptom of remember a few slides back, atherosclerotic coronary artery disease. So that atherosclerosis. It can be triggered also by a large meal or sudden fear. Also, it can be triggered. I would hate for my chest pain to start because I had such a big meal. So when increased oxygen demand goes away, the pain typically goes away. So like we talked about, when it relaxes, then the pain typically is going to go away. The angina pain is commonly described as a crushing, a squeezing, or like somebody standing on your chest. Somebody's standing on my chest. I got an elephant on my chest. You'll hear that, a big pressure on my chest. So it's usually felt in the mid portion of the chest under the sternum. Under the sternum. It can also radiate to the jaw and the arms, typically or frequently in the left arm, mid back, or the epigastrium. Okay. It usually lasts about 3 to 8 minutes, but rarely does it last any longer than 15 minutes. It can also be associated with shortness of breath, nausea, and sweating, so almost like classic signs of AMI. Shortness of breath happens too because of your breathing. You're in pain, so it hurts to even breathe. You have all the other stuff going on. You're already having an issue with perfusion, so that pain is going to come about as well. So a lot of times it disappears pretty promptly with rest. If we give them supplemental oxygen, or if we give them nitroglycerin, or NTG for short, NTG. All right, when you do your documentation, NTG means nitroglycerin. So although angina does not usually lead to death or permanent heart damage, it is a warning sign that should be taken pretty seriously. All right, unstable angina. So it's characterized by pain or discomfort that occurs in the absence of a significant increase in myocardial oxygen demand. All right, so stable angina, so that was unstable. Now stable angina is characterized by pain in the chest of coronary origin that occurs in response of or to exercise or some sort of activity that increases the demand of the heart muscle that is beyond the heart's capacity to increase its own blood flow. So patients experiencing chest pain or discomfort should always be treated as if they're having an AMI or an acute myocardial infarction. So the pain of AMI signals the actual death of cells in the area of the heart where the blood flow is being obstructed. So once it's dead, the cells cannot be revived. They will turn to scar tissue, and they become a burden to the beating heart after that. So about 30 minutes after blood flow is cut off, some heart muscles begin to die. All right. After about 2 hours, as many as half of the cells in the area may be dead. After 4 to 6 hours, more than 90% of the cells will be dead. So opening the coronary artery with either clot busting or thrombolytic drugs or angioplasty, which is going to be the mechanical clearing of the artery, it can prevent permanent damage if it's done within the first few hours after the onset of symptoms. Do you see where the time frames are coming from now? So that's why immediate transport is going to be essential. So the faster we get on scene, the faster we do a proper assessment, the faster we get them transported, right? This is going to greatly enhance their chances for saving that heart muscle. All right, some signs of AMI. So it's more likely also to occur in the left ventricle. Some signs and symptoms of AMI, they can include some of the following stuff that you see here. So sudden onset of weakness, nausea, and sweating. All right. or diaphoresis, sweating, diaphoretic. Chest pain, discomfort, or pressure that's often crushing or squeezing that doesn't change with each breath. That's the key factor. If it doesn't change with each breath, it's just the constant pain, the pressure, the discomfort, then you might need to look at this. So pain, discomfort, or pressure in the lower jaw, the arms, like the left arm, that's common. The back, in the middle of the back, the abdomen or high abdomen, or in the neck. Okay. Also, irregular heartbeat and syncope. So, can somebody tell me what syncope is? What is syncope?
Fainting.
Fainting. That's right. So, it's just another word for fainting. Also, shortness of breath to include. So, let me back up. So, when we talk about somebody fainted or fainting and we put it in our documentation, we want to use the word syncope or syncopal episode or something like that. Not fainting, fainted, or anything like that. Medical terminology. Shortness of breath. Otherwise, in medical terminology, or if we're documenting it, you can put SOB. Nausea, vomiting. All right. Pink, frothy sputum. And then sudden death. Signs and symptoms of AMI. So the pain of AMI differs from the pain of angina in 3 different ways. So it may or may not be caused by exertion, and it can occur at any time. Sometimes when a person is sitting quietly, or even when they're sleeping, they wake up and they start feeling it, then that can be it. So it doesn't resolve in a few minutes. So it can last between 30 and several hours. 30 minutes to several hours it can last. It may or may not be relieved by rest or nitroglycerin as well, or NTG for your documentation. Not all patients who are having AMI experience pain, or do they recognize it when it occurs? So when called to a scene where the chief complaint is chest pain, you want to complete a thorough assessment for these patients, no matter what the patient says. All right, some physical findings of AMI and cardiac compromise can include some of the stuff that you see here. So your general appearance, they're going to have that fear, that impending sense of doom, nausea, poor circulation. So they're going to have that lack of color, cool, pale, diaphoretic, right? Their pulse is generally going to be faster or irregular, or it can also be bradycardic. Bradycardic means low, be low, low. Their blood pressure is going to be decreased, normal, or it can be elevated. All right, so that's why we got to look at our patient, right? Cool, pale, diaphoretic, chest pain that doesn't go away. Nothing makes it better or worse. You can't touch it and it hurt any worse or make it any better. Their respiration is going to be normal, or they're going to be rapid and labored. Because of the pain, there'll be a lot of times they'll be taking short breaths or what have you, or it can be something that's affecting on the perfusion side as well. Their mental status, the sense of impending doom, that feeling of impending doom, like I'm gonna die. So as you can see here, the AMI can have 3 serious consequences. Pretty easy to figure out, right? Sudden death, pretty serious. Cardiogenic shock, and then congestive heart failure, or CHF. A dysrhythmia, or a rhythm that's not regular, right? Dysrhythmia, an issue with the rhythm, problematic rhythm. It's going to describe an abnormality of the heart rhythm. That's what dysrhythmia means. So premature ventricular contractions are extra beats in a damaged ventricle. So extra beats in that damaged ventricle is going to be a PVC, premature ventricular contractions, PVC. So they're harmless and common. It's common among healthy among healthy people as well as in sick people also. All right, tachycardia. So tachycardia, tachy meaning fast, not tacky meaning as in terrible or unprofessional or what have you. Tacky as in fast. Think of a tachometer on a car. All right. So tachycardia. So that describes the rapid beating of the heart, and that's at 100 beats a minute or more. So heart rate of 100 or more, then that's considered tachycardic. Bradycardia describes unusually slow beating of the heart, which is at 60 beats a minute or less. Now, I stay in bradycardia. My watch is dead. I was going to check it, but I stay pretty well bradycardic by this standard, and it's all dependent on what is normal for each patient. Because my heart rate at resting is about 54, not far, but it's a little bit less. And some other people's a little bit less. It's always good to ask, is this normal for you? All right, so then we talk about ventricular tachycardia, which is going to be the ventricles are pumping very fast, right? Ventricular tachycardia. So this describes a very rapid heart rhythm of about 150, so 150 to 200 beats a minute. So 150 to 200 is going to be ventricular tachycardia. So so what can happen from ventricular tachycardia is that can deteriorate into ventricular fibrillation. All right, you go from beating really fast to now it just starts fibrillating. So ventricular fibrillation describes the disorganized, ineffective quivering of the ventricles. Okay. So when that happens, no blood is pumped through the body, and the patient usually becomes unconscious within a few seconds. So defibrillation, it might convert this arrhythmia. Might. You're hoping it will. All right, so what is defibrillation, you ask? So defibrillation is the process of shocking the heart with a specialized electrical current to restore normal cardiac rhythms. So it can save lives if the shocks are delivered within the first few minutes of sudden death. CPR must be initiated until a defibrillator is available. So we got to start with that CPR, right? Got to start with that CPR. When the defibrillator becomes available, then we can use it. So the chances of survival diminish approximately, if you remember from your CPR class, so the chances of survival diminish about 7 to 10% each minute until defibrillation can be accomplished. So asystole is the absence of all heart electrical activity. Asystole, right? Lack of A, and then systole, remember, is that pump. So no pumping. So that's the absence of heart electrical activity. None in there. So a defibrillator, like an automatic external defibrillator, cannot shock on asystole because there's nothing to shock. It's about as good as putting it on this table here, on this desk. Okay. So it usually, that's why we have to continue CPR in hopes that we will cause that electrical to possibly come back and give us something to shock. So it usually reflects a long period of ischemia. So it's been going on for a while. The ischemia or that injury has been going along for a while, and now it's caused all the electrical to go haywire and just stop. So nearly all patients with asystole will die. So nearly all. It's a very rare event for them to come back. It happens, but a lot of them will die. All right. So cardiogenic shock. So shock occurs when body tissues do not get enough oxygen. We've talked about this before. And it causes body organs to malfunction. So cardiogenic shock is often caused by a heart attack. So the heart lacks the power to force enough blood through the circulatory system. It's more common in an AMI affecting the inferior and posterior regions of the left ventricle. So it's very important to recognize shock in its early stages. That cool, pale, diaphoretic, things like that. That's what we're looking for. Altered mental status, things like that. Recognize those signs of shock. Congestive heart failure, or CHF, it often occurs within the first few days after a myocardial infarction. So CHF develops when increased heart rate and enlargement of the left ventricle no longer make up for the decreased heart. Okay? No longer make up for the decreased heart. All right, so CHF, that's repeating it, CHF develops when increased heart rate and enlargement of the left ventricle no longer make up for the decreased heart. I don't know why I left that off function. My note here is cut off too. So we call it congestive because the lungs become congested with fluid. And we call that pulmonary edema. So once the heart fails to pump effectively, then that's what all that's going to cause. So that congestive part is pulmonary edema. It's congesting up the lungs. So it can occur suddenly or slowly after months of being there, after that ischemia, right? Or after that AMI. So in acute onset CHF, severe pulmonary edema is accompanied by pink frothy sputum and severe dyspnea, right? So some sort of dysfunction of the breathing. So with right-sided heart failure, right-sided, all right, the blood backs up in the vena cava, and this causes fluids to collect in other parts of the body. That's why right-sided heart failure, a lot of times you'll see in the feet and the legs, they'll get edema. They'll get edema in them. Okay? And that's called dependent edema. So a lot of times you'll see that in the feet and legs. So right heart failure can result in an inadequate supply of blood to the left ventricle. This resulting in a systematic drop in blood pressure. Okay? So patients may present with both signs of left and right-sided heart failure because left-sided failure often leads to right-sided failure. All right, your hypertensive emergencies. So hypertensive emergencies involve any systolic blood pressure greater than 180 millimeters of mercury, mmHg, millimeters of mercury, or a rapid increase in the systolic pressure. So a lot of times this will come on with a sudden severe headache. That's a common sign for it. Some other symptoms are going to be like your strong bounding pulse or a ringing in the ears as well. All right, some other symptoms for this: nausea, vomiting, dizziness, warm skin, like dry or moist, warm skin, nosebleed, altered mental status, AMS, sudden development of pulmonary edema. And then also some things that you'll see here. So if it's untreated, those hypertensive emergencies can lead to stroke because you're putting a lot of pressure on the brain or a lot of the vessels in the brain, or a dissecting aortic aneurysm. So there's so much pressure in the aorta, or there's so much pressure in these arteries that it will burst them. It's kind of like a water hose that's full of water on a hot day. You leave it out long enough and it'll start to expand and then it'll pop. So we got to transport those patients to the hospital as quickly and safely as possible. We may need to consider ALS assistance. depending on the transport distance and the time that you have there. All right, so aortic aneurysm describes a weakness in the wall of the aorta, just like we talked about. So the aorta dilates like a water hose, right, at the weakened area, which makes it susceptible to rupture, just like in a water hose on a hot day. You leave it on, and you don't have it running. So if it ruptures, blood loss will cause the patient to die almost immediately because it's like the aorta, large artery bursting, and then it's just going to pump that blood out real quick through that, and all that blood will be lost internally. Very quick. So uncontrolled hypertension is going to be the primary cause of a dissecting aortic aneurysm. So a dissecting aneurysm occurs when inner layers of the aorta become separated. Hold one moment. So a dissecting aneurysm occurs when inner layers of the aorta, it becomes separated, allowing blood flow at a high pressure between the layers. All right, so the question was asked, does draining blood help hypertension? No, because it's just going, so now you're losing that volume. So how you're going to fix that is by fixing the container, two, the dilation of the other cells, or not the other cells, but the veins and the arteries, helping that out and relieving that pressure there, not relieving it through what we used to call bloodletting. All right, so bloodletting, when we talked about draining blood to help hypertension, so we called that bloodletting. And the process of bloodletting was that you opened up a vein or something of that nature. You open it up just long enough to bring that blood pressure down. Okay. And so really what you're doing is you're creating hypovolemia. All right. You're creating exsanguination. Remember that major bleeding we're supposed to be stopping? You're basically creating that to lower that blood pressure. So it doesn't work because whatever is going on with your body is still happening. All right, that's still going to happen. And if somebody lets that blood out, then it's going to exacerbate any further on, underlying conditions that are there that's causing the hypertension in the first place. So what we have to do is we have to go with the signs and symptoms, follow the pathophysiology, and fix those things. Fix the veins that are dilated, fix the atherosclerosis. We have to fix something there to create that from happening. Fix the cardiogenic shock. That's how we're going to actually bring that blood pressure back down. But no, we don't practice bloodletting anymore. Would it help? To an extent, it would, but it's not going to help in the long run. All right, so aortic aneurysm, continue on with that. Signs and symptoms include very sudden chest pain located in the anterior part of the chest, right? More towards the front, or the back, or in the back between the shoulder blades. All right, a lot of times they describe it as a burning. It's like a bad burning sensation, that chest pain sensation. A lot of times it's described as burning. So it may be difficult to differentiate the pain of a dissecting aortic aneurysm from that of a acute myocardial infarction or a classic heart attack. Either way, we got to transport those patients to the hospital as quickly and as safely as possible. All right, so on this table, on this slide, it's going to list the differences between pain presentation between AMIs and aortic aneurysm. Get a chance to take a picture there. I'll get my head out of the way at some point. Save it or whatever you want to do. All right, let's move on to a scene size up. So scene size up, we're going to show up. We're going to ensure the scene safety, right? Scene safe BSI, or BSI is my scene safe. We're going to determine the nature of illness are in these patients. We're going to use information from the dispatcher and clues at the scene, and then any comments from the family members, bystanders, things like that. We're going to use those. All right, from our primary assessment, so this is very important too. We're going to form a general impression of this patient, sick or not sick. If the patient is unresponsive and is not breathing, we're going to begin CPR quickly, right? Starting with chest compression, we're going to call for an AED. Delegate that to somebody. Point, say, hey, you, grab an AED, right? We're going to assess the patient's airway and breathing from there. If we're doing the CPR, hey, are they actual breathing? Or if we do have that, so on and so forth, we're going to tend to life threats first. If dizziness or fainting has occurred due to cardiac compromise, we need to consider the possibility of a spinal injury from a fall. So if they happen to fail during this, we need to consider that. Assess the breathing to determine whether the ailing heart is receiving adequate oxygen. Okay. So shortness of breath with no signs of respiratory distress. So one we're going to look at for that, if oxygen saturation is less than 95%, we're going to administer oxygen at 4 liters a minute via nasal cannula. All right, so less than 95%, no signs of respiratory distress, but they have shortness of breath. We're going to go with nasal cannula, 4 liters a minute. If they do not improve quickly, we're going to apply oxygen with a non-rebreathing mask, NRB, at 15 liters a minute. If they're not breathing or inadequate breathing is occurring, we're going to apply 100% oxygen with a bag valve mask. BVM, 100% oxygen. All right, for pulmonary edema, we're going to make sure that if we're listening to their lungs and it sounds like they got that poppy paper or that bubble wrap in their lungs, or it sounds like they're breathing through water, then we may need to administer that positive pressure ventilation with a bag mask device or CPAP. All right, that CPAP is going to help push that fluid out of the lungs because it keeps everything open, right? And when it keeps it open, it's just going to push it out. All right, so next we're going to assess the patient's circulation. We're looking for pulse rate and quality, skin color, moisture, temperature, capillary refill time, right? We're going to consider any type of treatment for cardiogenic shock early to reduce the workload of the heart. No bloodletting. We'll position the patient in a comfortable position of comfort, right? Usually that's going to be setting up and well supported. Okay, so Fowler position, semi-Fowler position, whatever they find to be most comfortable. We're going to, at this point, now that we've done that, we're going to make a transport decision based on whether you are able to stabilize life threats during the primary assessment. So from there, the remainder of the assessment can be performed en route if time allows this. So most patients with chest pain should be transported immediately. We're going to make sure, though, that we follow our local protocol for determining what receiving facility is the most appropriate. Also, we can determine whether to use lights and sirens for each patient. Partially, it's going to be based on estimated transport times. So as a general rule, patients with cardiac problems should be transported in the most gentle, stress-relieving manner as possible. That's going to help them out. Stress exacerbates injury. Stress exacerbates injury. All right, for our history taking. So we're going to investigate the chief complaint. We're going to look at it this way: because the patient's experiencing AMI, they will have different signs and symptoms. Seriously consider all the complaints of chest pain or discomfort, shortness of breath, and dizziness, we want to make sure that we definitely consider those when looking for that AMI. If the patient is experiencing dyspnea, all right, difficulty breathing, we got to look at some things. Is it due to exertion or related to the patient's position? So is it continuous or does it change? Like with deep breathing, does it change with deep breathing? If the patient has a cough, does it produce sputum? What does that sputum look like? Does the patient have nausea and vomiting? Do they have fatigue, headache, and or palpitations? Palpitations of the heart, right? Ask about recent past trauma if they've had any. We want to also obtain the sample history from a responsive patient. We want to ask some of the following questions. So some of these questions would be great to ask. So have you ever had a heart attack? Have you been told that you have had heart problems? Do you have any risk factors for coronary artery disease? You may also want to ask things like, what allergies does the patient have? Ask that too. So we always want to make sure we include our OPQRST, onset, provocation, quality, radiation, severity, and time. We want to get those questions when obtaining the symptoms as part of the sample history as well. Sample. Signs and symptoms, allergies, medications, past pertinent history, last oral intake, and events leading up to present illness. All right, so on this table, it displays the OPQRST mnemonic for assessing pain. So definitely take a look. As a matter of fact, I'm going to do content only on this so y'all can take a picture because it's quite big and I can't move out of the way. All right. Now we're going to be doing a patient assessment here in just a little while, full out assessment. This will probably be good to have on you. All right. Moving on. All right. So secondary assessment. So we're going to focus on the cardiac and respiratory systems at this point. Focus on the cardiac. So this is a focused exam, right? So we're going to focus on the cardiac and respiratory systems. We're going to look at circulation. We're going to look at respirations as well. We're going to measure and record the patient's vital signs. So when you take a pulse, remember you're going to take that pulse for 30 seconds, multiply it by 2. You're going to, while you're doing that, you may stay there and act like you're still taking the pulse. And so finish your pulse in that 30 seconds, multiply that by 2, and then very quickly turn around the next 30 seconds and watch their chest for the respirations. Get that for 30 seconds and then multiply that by 2. We'll also take the systolic and diastolic blood pressures in both arms, and we're going to compare those numbers. So if it's available, you can also use pulse oximetry, SpO2, right? If continuous blood pressure monitoring is available, use it as well. So do it by hand first, and then you can do the continuous ongoing with a monitor. You want to repeat the appropriate intervals and note the time that each set of vital signs is taken and recorded. That's because we're trending at this point, right? We're trending. So in patients with chest pain, it's very valuable to have a 12-lead ECG tracing from as early as possible after the onset of pain. That's where we have to recognize that need for ALS. All right, so we can go ahead and start that, get that 12-lead. We got chest pain. They meet the sign. They meet the sign and symptoms. Pale, cool, diaphoretic. This, and this is going on. Yep, I do. I do have the impression that they're doing, or that they're having an active AMI. I need to get ALS here as possible, or as soon as possible, or meet up with them so that they get a 12 lead ECG, so that we can get an accurate picture of the heart and start trending what's going on with this patient, so we can improve their outcome. All right, for reassessment, we're going to repeat the primary assessment by checking to see whether the patient's chief complaint and condition have improved, or is it not improved? Is it deteriorating? We're going to reassess the vital signs at least every 5 minutes, or anytime any type of significant change in the patient's condition occur. Also, sudden cardiac arrest is always a risk for these patients that are experiencing cardiovascular emergencies. Need to be ready. Need to be ready to provide that CPR, those life-saving measures. So if cardiac arrest occurs, at that point, you know that the AED, if an AED is immediately available, we're going to use it. If it's not, we're going to perform CPR immediately until the AED is available. We're going to reassess all of our interventions. We're going to provide transport if it's not performed already. And then we're going to make sure that our communication and our documentation is on point, right? So we're going to alert the emergency department about the patient's condition and the estimated time of arrival. We're going to follow the instructions by med control if we have any. And then we're going to be sure to document your assessment and treatment of the patient from there. All right. Emergency care for chest pain or discomfort. So the emergency care of that. So emergency medical care for chest pain or discomfort. So ensure a proper position of comfort. All right. So ask them, how do they feel better? What makes them feel better? If need be, allow the patient to sit up if that's the most comfortable. You want to make sure to loosen any type of tight clothing. Give oxygen where it's indicated. Continually reassess oxygen saturation and the patient's respiratory status. Always keep up with that. Use a nasal cannula for patients with mild breathing problems, right? Shortness of breath, but no, we don't have any other type of issues, just shortness of breath, but we don't see any perfusion issues. We can give them a nasal cannula on 4 liters. If you see anything more than that, then use an NRB or a normal breathing mask on 15 liters of oxygen for our more serious respiratory difficulties. So if signs of pulmonary edema are present, we may want to use a CPAP. That may be indicated. All right, so we're going to hear that through auscultation, right? It's going to sound like they're underwater, breathing underwater. We're going to hear the air bubbles, or we're going to hear the packing bubbles, right? Sound underneath there, like muffled bubble wrap. So at that point, when we do our chest, you're going to hear a lot of times in the lower areas, or on the back, you're going to hear it. And that CPAP is going to help push that fluid out of the lungs. So assist any type of unconscious patients with breathing, as well as those with obvious respiratory distress, right? So if there's no breathing going on, BVM, right? CPAP's not going to help that. We got to BVM that patient. We got to be the mechanical. No breathing, you become the mechanical breathing for that patient. So also, depending on local protocol, you need to prepare to administer low-dose aspirin and assist with prescribed nitroglycerin, or NTG. The low-dose aspirin, remember, that's 81 milligrams. We're going to give 4 of them, 4 81 milligram aspirin for 325 milligrams. All right. Or 324, sorry. 324 milligrams. My math is terrible. So the aspirin, what the aspirin does, it's going to prevent new clots from forming, or new existing clots from getting bigger. The recommended dose is going to be 162 to 324 milligrams. We're going to use the low dose aspirin for this, or the 81 milligram aspirin, baby aspirin. 324 milligrams, 4 tablets. All right, nitroglycerin, or NTG. It's available in a very small tablet. It can also come in a spray, and it can also come in a skin patch. You can assist with those. The spray, the sublingual pill, the way that they're going to take that is you're going to say, hey, to take this pill as you assist them, keep it under your tongue. Don't swallow it. Don't chew on it. Keep it under your tongue. The spray, if they have the spray, you can assist. They have to hold their tongue up and you spray. One spray equals as much as one pill. And then the skin patch can be applied to the chest directly. You can assist those patients. Make sure make sure you got your med control online. All right. MOA, or mechanism of action, for your nitroglycerin. So it's going to relax the muscles of blood vessel walls. It's going to dilate coronary arteries, right? It's going to increase the blood flow and the supply to the heart. So it also decreases the workload of the heart while it's doing this. All right, some side effects of it are going to be decreased blood pressure and severe headache. Yep, nitro can be a paste. I haven't seen nitro paste in a long time, mostly because of the effects that it has if it gets on the EMT. But I haven't seen nitro paste in quite a while. The side effects for this are going to be decreased blood pressure and severe headache. All right. And it's headache because it dilates, right? It's going to dilate those vessels in the head, and that can create severe headache in those instances. That decreased blood pressure, that's going to be very important when we start doing our assessment. If we have any indication that this could be right-sided heart failure, remember, right-sided heart failure increases the chances for the blood pressure to be low. It can actually drop out for that right-sided heart failure. So if you give them nitroglycerin, then you can bottom that patient out. All right. More need to have that ALS on scene to go ahead and get IV started, things like that. Something else, when we have our patients that have these issues, we're given that nitroglycerin. What are we going to do first before we ever give our patients any type of drugs? We're going to make sure that we have what on hand? Our first set of what? Yep, that's right. So our first set of vitals. All right, and what does our blood pressure need to be before we give nitro? That's right, 100 millimeters. So your systolic needs to be 100 or above. Absolutely. All right, nitroglycerin, just like we talked about, those contraindications. What would contradict us giving nitroglycerin where we don't want to give it? So if your systolic blood pressure is less than 100 millimeters of mercury, if you have a presence of a head injury, if you use any type of erectile or ED drugs within 24 to 48 hours, like Cialis or Viagra, anything like that, now they have the HIMS, they got all sorts of stuff. So, and people without erectile dysfunction are taking these drugs as well. So for your males, even for females, they're starting to do this as well. Make sure we ask these questions. Okay. Also, the maximum prescribed dose has already been given, so that's going to be a contraindication. Usually it's about 3 doses. If 3 doses has already been given, then we're not going to give any more nitroglycerin. All right, so continuing on, cardiac monitoring. So cardiac monitoring, for an ECG to be reliable and useful, the electrodes must be placed in consistent positions on each patient, just like we talked about earlier, right? We've already iterated. We're not going to beat this dead horse. So certain basic principles of this should be followed to achieve the best skin contact and to minimize artifact. Artifacts can be those when you see the ECG, those squiggly lines that look like they don't make sense, or sometimes they can throw people off. Even movements can become artifact. So we're going to do that to minimize artifact in the signal that's coming across that ECG. In order to do that, we have to ensure the correct placement of the electrodes. So some of the guiding principles for this, it may occasionally be necessary to shave body hair from the electrode site. Now, some people talk about like the electrodes to the AED to stick them on and then rip them off. That does not work as well as people like to think that it does. So it doesn't rip off near as well. Plus that, and you've wasted a set of AED pads or AED electrodes just by trying to rip hair out of their chest. The best way to do this is to make sure there's a razor in there and then use the razor to shave down the patient, right? So what we're talking about here, you're going to rub the electrode site briskly with an alcohol swab before the application. So what that does is to remove any type of oils, dead tissues from the surface of the skin. So it's going to make it better to stick with. Okay. You're going to attach the electrodes to the ECG cables before placement. So attach the electrodes to the actual ECG. That way you're not pressing it on them or having to clip it to them or what have you while the pads are there. You're already going to have the electrodes in place with the cables. You're gonna confirm that the appropriate electrode now attached to the cable is placed at the correct location on the patient's chest or limbs. All right, the next picture will show you some of the words. There we go. Okay. So you see here, this is going to show you the correct placement. All right. So the way that I remember this, because I'm a firefighter and we're completely awesome and having to remember things that we will forget 5 seconds after you tell us, is you see here smoke over fire and then clouds over grass. Okay. So red, black, white, green. All right. This is just like we're looking at the patient. So if we're looking at the patient, this is going to be what side of the patient? Where's this located? On the right side. That's right. That's right. White to the right. So white to the right, and then you say clouds over grass, and then smoke over fire. All right. So what you may see also is you'll see like something like RA will be on it, right arm. Okay. And then you'll see on there green, you'll see RL, and then you'll see LL, and then you'll see LA. All right, and there's your different lead placements for a 12 lead. All right, and I'll move out of the way, or I'll move this out so you can take a picture or save it or what have you. No. You may be able to assist ALS with this. But no, in order to do a 12 lead, you'd have to be trained to interpret it. You can if your particular place where you work at allows, but you can, right? But you have to know how to interpret that as well. Okay. All right. So once all the electrodes are in place, you're going to switch on the monitor. You're going to print a sample rhythm strip. All right. Print you a sample off. If the rhythm strip shows any type of artifact or tells you that there's something wrong, it'll say something like lead placement, lead, or lead 6 is blah blah blah, what have you, lead 1, no reading on lead 1 or what have you. It'll try and diagnose the problem depending on the type of monitor you have, and then you just make sure that everything's in place. Things that happen is like riding down the road, you're not going to get an accurate strip. If the patient is moving around, you're not going to get an accurate strip. So a lot of times we'll tell the patient, be like, hey, I need you to no talking, no moving, no nothing, just regular breaths for the next, 10 to 20 seconds. And then it'll show a lot less artifact in doing that. All right. So if the strip shows any type of artifact, verify that the electrodes are firmly applied to the skin, and then you'll monitor the cable. Make sure the monitor cable is plugged in correctly. Make sure it's plugged in all the way. Also. All right. So heart surgeries and cardiac assistive devices. All right. Heart surgeries and cardiac assistive devices. So over the last 40 years, hundreds of thousands of open heart operations have been performed to bypass damaged segments of coronary arteries to the heart. So in a coronary artery bypass graft, a blood vessel from the chest or the leg is sewn directly from the aorta to a coronary artery beyond the point of wherever this obstruction is at. All right, so some things that you'll see is like the percutaneous transluminal coronary angioplasty. Big words, right? So it dilates the affected artery rather than bypassing it, and it involves some of the steps that you're going to see here. So what happens is they take a tiny balloon that's attached to the end of a long, thin tube, and it's introduced into the large artery. So the tube is threaded into the narrowed coronary artery, and then it's inflated. The balloon is then deflated, and the tube in the balloon is then removed. Sometimes a stent is placed inside the artery to keep it open as well, to keep it from collapsing down. All right, so patients who have had bypass procedure may or may not have a long scar on their chest. Part of the zipper club. Looks like a zipper's been installed on their chest, right? So part of the zipper club. So treat chest pain in a patient who has had any of these procedures in the same way you would treat chest pain in patients who have not had heart surgery. So some people have cardiac pacemakers as well to maintain a regular cardiac rhythm and rate. We talked about it's a little bit smaller than a deck of cards. It'll be installed in their chest. It's a square looking or a circle looking piece. It'll be right there in their chest. It can be on either side. They also have defibrillators that are like that. They have GPS that are inside of them, all sorts of stuff. They're pretty neat. So the way it is, they're inserted with the electrical system of the heart. All right. When it's damaged enough, they'll insert those, and if it can't function properly, they'll put those in. So their battery-powered devices delivers an electrical impulse through wires that are in direct contact with the myocardium itself. The generating unit typically resembles about a silver dollar and is usually placed under the heavy muscle or the fold of the skin in the left upper portion of the chest, typically. All right. So EMTs, they normally do not need to be concerned about problems with pacemakers. When they do not function properly, pacemakers can have a patient experience a syncope or fainting, right? Dizziness or weakness due to an excessively slow heart. So the pulse will ordinarily be less than 60 beats a minute for this. So a patient with a malfunctioning pacemaker should be promptly transported to an emergency department. With an AED, if an AED is used, the patches should not be placed directly over the pacemaker. We all learned this in the AHA classes, right? Or Red Cross, whichever one you're taking. So automatic implantable cardiac defibrillators they're sometimes used by patients who have survived cardiac arrest before due to ventricular fibrillation. So those devices continuously monitor the heart rhythm and deliver shocks as needed. So you'll have some people that'll have those, and you'll come to their house like, oh, it's shocking me, it's malfunctioning. No, it's working just fine. It's saving you right now. So we're going to treat those patients like all other patients have an AMI, including if we need to performing CPR and also using an AED if the patient goes into cardiac arrest. So the electricity from an automatic implantable cardiac defibrillator is so low that it's not going to have any effect on the rescuers if it goes off because it's in direct contact with the heart. It's not trying to go through anything to get to the heart. It's got direct contact, so it doesn't have to be as strong of a hit. All right, you also have what's called an external defibrillator vest. So a vest with a built-in monitoring electrodes and defibrillation pads, which is worn by a patient under his or her clothing. So the vest is attached to a monitor worn on a belt or hung from a shoulder strap. So this device, it uses a high energy shock because it's external, right? Similar to what an AED does. So you should avoid contact with the patient if the device warns that it's about to deliver a shock. So the vest should remain in place while CPR is being performed unless it interferes with compressions. If it's necessary to remove the vest, you simply remove the battery from the monitor and then remove the vest. All right, I've dealt with these on a few occasions. I had a neighbor that actually had this device here. So, and we went over it at nauseum, and then I taught it to the fire departments and things like that to make people well aware. And generally, if you have these in your area, you should know about them because once you come across that patient for the first time, hook them up to a monitor or take a pulse, it's gonna wake you up. All right, so the left ventricular assist device, or what's called an LVAD, it's used to enhance the pumping of the left ventricle in patients with severe heart failure or in patients who need a temporary boost due to an MI. So the most common ones have an internal pump unit and an external battery pack. It almost looks like shoulder holsters that they have on them, or an external battery pack that'll be like in a small case. It almost about the size of an AED box. So the pumps are almost all continuous. So most patients do not have a palpable pulse. All right, that's the wild part. So you'll get there and you'll try and check their pulse and they won't have a pulse because it constantly runs. There's a little pump in there, a little motor. If you have your ears or if you have your stethoscope, you can put it on their chest and you'll hear a whirring. It's like a because the pump running. And that's pumping their blood or continuously pushing blood through. okay, to assist the left ventricle. All right, so the problem that you have is unless the device, so the heart is still beating, and all this is doing is it's creating a pump, but you can't feel the pulse. But no, the heart's not doing absolutely nothing. It's still, the beat is still going. It's just so weak, or this thing is constantly creating that pressure, that constant issue, or that constant. Uh, I guess what I'm saying is pushing that pushing that oxygenated blood through the body for the ventricle. So the left ventricle is not working appropriately. So you're not going to get that pulse like you usually would. But the heart's not doing anything. They can go into cardiac arrest. They go into cardiac arrest. You can perform CPR. The problem is that if you perform CPR on these patients, you can actually dislodge it, and if you dislodge it, that's just like having a huge hole in the heart, and it's going to kill them. The thing is, if they need CPR, they need CPR. It's in there pretty good, it's in there pretty solid, so it shouldn't knock out, but it can. These patients, if you ever run across one, they are very well versed, and also if they have a spouse or a significant other or somebody that's with them, that lives with them, or that stays with them, then they are very well versed on how this operates. It's got alarms and alerts, and that's a lot of times what'll happen is you'll have a low battery alarm or something of that nature that'll go off, and they'll call the fire department or an ambulance and get you to come out there and check on the patient. These are monitored 24/7 back to wherever they were, wherever in the area that they live at. Most likely where it was installed at is monitoring that patient, and it will make a phone call or an alert to that hospital or that facility or that doctor as soon as something happens. And then that facility will contact them and contact emergency services to see what's going on. Generally, if they have those patients, they want you to transport everything with that patient and transport them straight to that hospital where they had it implanted, so that they can, or at a place where they do that type of surgery, so that they can diagnose and figure out what's going on. So if you have any doubt on what to do with those patients, just contact your med control, and they should be able to do it. But unless the device malfunctions, you shouldn't have to deal with the device itself. So that's one thing with those patients. The non-palpable pulse, you're not going to feel it really. And this patient's going to be sitting there talking to you. It's going to feel a little weird when you're doing that. Also, if you hook them up to a monitor, you're just going to see a wavy line, and it's going to have a lot of tick marks on it as the line waves. These patients, like I said, they're very well versed in what's going on. They have car hookups, airplane hookups. They can plug it into a wall, you name it. They're going to have everything on them. If you have one in your area, you should know about it. Somebody should have contacted the ambulance company local or the fire department local to have a class or to give them some sort of training on it as well, in case they have to respond to it. Should. Doesn't mean that always happens, but should. All right, cardiac arrest. So cardiac arrest is the complete cessation of cardiac activity. All right, it's arrested, not doing nothing, right? So that's going to be the electrical, mechanical, or it could be both. It is indicated in the field by the absence of a carotid pulse. All right, so if there's no carotid pulse, probably in cardiac arrest. So cardiac arrest was almost always terminal until the advent of CPR and external defibrillation in the 1960s. So with good initial CPR, early defibrillation, and access to advanced care, it is going to be absolutely possible for some patients to survive a cardiac arrest without neurological damage. All right, so remember, your heart stops, there's no oxygen being brought to the brain starts to die. After 4 to 6 minutes, there's irreversible brain damage. so on and so forth. You remember how it goes in class. All right, so an AED, an automated external defibrillation. So it involves the use of a small computer, which is called an automated external defibrillator, AED, that analyzes electrical signals from the heart. So what's that tell me? Is that it's only going to analyze the electrical signal. If there is no electrical signal, such as like asystole, it's not going to analyze it. It's like setting it on that table, right? So what it's going to do, it's going to identify ventricular fibrillation, and it is extremely accurate at it. And at that point, it's going to administer a shock to the heart when it's needed for that. All right, so VFib, VTAC, anything like that, ventricular fibrillation, that's what it's going to monitor and look for. All right, so when it does hit, it doesn't necessarily mean that it's going to shock it back to normal sinus rhythm. It just means it's going to hit it in the hopes that it goes back to normal sinus rhythm or a rhythm that it can possibly shock again or what have you. All it's doing is delivering the shock. It doesn't deliver a particular shock for a particular result, just a shock. So AEDs, they do come in different models. All the models require some operator interaction, like applying the pads or turning on the machine. The first thing you do is turn on the machine. So the operator must push a button to deliver an electrical shock. Okay. Please listen, wait, pay attention to how that happens. So when it starts to charge up, then when it starts blinking, the light turns on, starts blinking, or whatever the operation is for that particular AED, then you clear everybody off of it. Clear everybody off the patient, and then deliver the shot. All right. So, so many of these AEDs, they use a computer voice. The computer voice synthesizer, what it does, it advises the EMT which steps to take, or anybody that's using it, what steps to take. So most of the AEDs are semi-automated and extremely accurate. All right, so there are some advantages of AED use, which can be quick delivery of an electrical shock, easy to operate, no need for ALS providers to be on the scene to use them. The remote adhesive defibrillator pads are safe to use. Larger pad areas with manual paddles, which means that the transmission of electricity is more efficient. So that the larger pad areas, it's got larger pad areas than what the paddles used to give. So it's going to be more efficient for it. So the pads are better, is what they're saying. Easier to use too. All right, so some other considerations for this. Not all patients in cardiac arrest require electrical shock. So all patients in cardiac arrest should be analyzed with the AED. Some do not have shockable rhythms. VFib, VTAC, right? VFib, VTAC, that's all it's going to hit. If it's anything other than that, it's considered a non-shockable rhythm. And so it'll say shock not advised. Doesn't mean that you stop CPR, doesn't mean that person's up and alive. It just means it does not have a shockable rhythm at that time. So you have to continue CPR until other indications say that you don't need to anymore. So asystole indicates that there's no electrical activity that remains. There's also something called pulseless electrical activity. It usually refers to a state of cardiac arrest that exists despite an organized electrical complex. So on a monitor, it'll look like normal sinus rhythm, or it'll look like some sort of rhythm is going on, but there will be no mechanical. So the mechanical won't be good, or won't be going on, which means you have to be the mechanical, right? CPR. But it will not shock that because it recognizes it as being an organized electrical complex. All right, early defibrillation is going to be essential intervention for patients experiencing cardiac arrest. Few patients who experience sudden cardiac arrest outside of the hospital, they survive. Few of them survive unless a rapid sequence of events takes place for that. All right, and in that rapid sequence of events, when we start talking about the chain of survival, right? So there are links in the chain of survival, and those are going to include the recognition of early warning signs and immediate activation of EMS, immediate CPR with the emphasis on high quality chest compressions, rapid defibrillation, basic and advanced EMS, ALS and post arrest care, and then also recovery. The chain. There's a figure with the link in the chains. All right, so CPR, it helps patients in cardiac arrest by prolonging the period between which defibrillation can be effective. Rapid defibrillation has successfully resuscitated many patients in cardiac arrest due to ventricular fibrillation. So if they have ventricular fibrillation, it has been very successful. So defibrillation, it works best if it takes place within 2 minutes of the onset of the cardiac arrest. So that's when it works. That's the most optimal time, within 2 minutes of cardiac arrest. So that's why we want to get AEDs everywhere, right? So if we have better access to them, better access to AEDs, better access to CPR, then your arrest success, your return of spontaneous circulation success goes way up. So there are some non-traditional first responders that are being trained to use AED. We go out and train people all the time within our company. The public, we have private companies that call us up and everything else. They're not necessarily trained EMR personnel, EMT personnel, but they can use AEDs, they can use oxygen, they can use first aid kits, they do CPR, so on and so forth. So the general public is becoming more knowledgeable in emergency medicine. So the fifth step in the chain of survival is ALS and post-arrest care. So with these patients, we're going to continue ventilation at 10 breaths a minute to achieve, remember we talked about that EtCO2 of 35 to 40 millimeters of mercury, that we talked about that capnography, right? We're going to maintain that oxygen saturation between 94 and 99%. We're also going to assure blood pressure is above 90 millimeters of mercury. That's our goal for blood pressure in our post-arrest patients. The use of targeted temperature management when the patient arrives at the hospital, that's something that we used to have these bear huggers and everything else, but they do that at the hospital. But what we can do inside an ambulance is control the temperature inside that ambulance. All right, keep them at a good temperature if we can. So cardiopulmonary and neurologic support, along with other advanced assessment techniques and interventions when indicated, we need to be able to cover those areas, right? So the final step in this chain is going to be recovery. So in that chain of survival, the final step is recovery. And it can take a year or longer. Many of the 10% of victims of out of hospital cardiac arrest who are fortunate enough to survive, we go into that recovery phase. No, so in post arrest care, they used to cool patients down. So it creates less stress on the heart, cooling the patient down. And so they would do that. Now in your trauma scenarios, we want to keep our patients warm, right? But in what they have found in post arrest scenarios is to keep those patients cool. Now, there's nothing that we can really do about that on the ambulance, get them to the hospital, and they'll regulate that. We're going to work on the shock side. All right, so when integrating the AED and CPR into patient care, we got to keep some of the following stuff in mind. It's important to work with the AED and CPR in sequence. We're going to apply the AED only to pulseless, unresponsive patients. We're going to make sure that we don't touch the patient while the AED is analyzing the heart rhythm, because we don't want it to think that something else is going on, right? And we don't want to touch them while we're doing a shock, because it's in use at that point. So the CPR must stop while the AED is delivering a shock. So before you hit that button, CPR's got to stop. Any other time, you're going to do compressions. So you can do compressions as it's being applied. You can do compressions up until the point it says stop CPR or don't touch the patient. As soon as it says shock advised, technically, if it says shock advised, you can go back to compressions while it's charging. Okay. And then once it charges, you can say, all right, who's going to hit the button? Or if it's yourself, then you back off, you let them make sure everybody's clear, hit the button immediately. As soon as they do the funky chicken, or as soon as they get shocked, or as soon as the shock is delivered, you go back to compressions. So that's how you eliminate that time off the chest. So you gotta eliminate all that time off the chest, because you are the mechanical for that, and you're building up that pressure to their brain, keeping their brain fed and the body fed, that oxygen. If you stop, as you stop, all that blood comes back down, and you got to start over each time. So if you minimize the time off their chest, then you're going to be able to keep that rate up. You're going to be able to keep that pressure up and that oxygenation going. All right, AED maintenance is important. I know, like at our airport, we do weekly inspections of our AEDs just to make sure that they're squared away. And then we also make sure that the batteries get changed out. The batteries do have expiration dates on them. The pads have expiration dates on them, so on and so forth. We make sure that we have inside the kit, that we have the razors, that we have all the stuff that needs to be with it. So you need to be familiar with the maintenance procedures that's required for the brand of AED that your service uses. So one good thing is to make sure you read the operator's manual. And there are 3 of the most common errors in using certain AEDs. All right, so failure of the machine to shock fine V-fib. That's an error. Applying the AED to a patient who is moving, squirming, or being transported can cause an error. Turning off the AED before analysis or the shock is complete, that can cause an error. Now, operator errors can include failing to apply the AED to a patient in cardiac arrest, not pushing the analyze or the shock buttons when the machine advises you to, also not pushing the shock button within 30 seconds. It'll de-energize. So keep that in mind. You have to push it within 30 seconds of it lighting up and being ready to shock. Pushing the power button instead of pushing the shock button when the shock is advised. You shut it off, it's got to start the process all back over if you turn it on. Make sure that the battery is properly maintained. Like I said, they have these special batteries in them. They're usually a special shape, special brand for that particular AED. They do have expiration dates on them. Check your equipment, including your AED, daily at the beginning of each shift. If you carry them on your trucks, they should be checked. Ours on the trucks are checked every day. In the facilities that we do inspections on, they're checked weekly for the airport, for our local places. We try to keep anybody else that does it. We try to encourage that they keep a record, or they have a facility manager that checks the AED weekly as well. So you can ask the manufacturer for a checklist of items that should be checked daily, weekly, and less often than that. So you can call the manufacturer and they'll provide you a checklist, which is really great when we're talking about our inspection programs, like for EMS or for the fireside. That may really help you out. Gives you another chance to interface with the public as well. So what you want to do is you want to report any AED failure that occurs while caring for a patient. You want to report that to the manufacturer as well as to the U.S. Food and Drug Administration. All right, U.S. FDA, I mean. So be sure to follow the appropriate EMS procedures for notifying those organizations if you need to pass that up the chain or what have you. Medical direction should approve the written protocol that you're going to follow for caring for the patients in cardiac arrest. The EMT team that you have and your service medical directors or quality improvement officer should review each incident in which an AED is which an AED is used. So your QI or your quality improvement, it involves both the individuals using AEDs and the responsible EMS system managers. The reviews, what we call run reviews, the run reviews should focus on the speed of defibrillation, the time from the call to the shock. All right, that's going to be the speed of defibrillation from the time that the call was made to the time shock was made. The shocks should be delivered within 1 minute of the call. All right, if that's possible, you'd be flying wherever you're at. So mandatory, so also mandatory continuing education with skill competency review is generally required for EMS providers. We have those all the time. So we got run reviews, we have training that we have to do, keeping up our CPR cards, all that good stuff, our CPR AED cards for provider cards. We have to do all of that. You also get it when we're talking about ACLS, PALS, all those classes as well. All right, emergency medical care for cardiac arrest. So when preparing to use an AED, it is the EMT's job to make sure that the electricity from the AED injures no one. So don't defibrillate patients in pooled water. Electricity will diffuse through the pooled water. A small puddle, snow, anything like that is fine. We want to make sure they don't have to be absolutely dry, but we want to make sure any excessive wetness to wipe off. That way, those the pads will stick better too. So just like I was saying, you can defibrillate a wet patient, but you want to make sure that their chest is dry at least. So patients that are touching metal, you don't want to defibrillate those patients that are touching the metal, just mainly because it can dissipate the electricity into the metal and then it's less effective. You don't want to touch it that others are touching because then it dissipates that electricity into those others as well. All right, so also you want to carefully remove a nitroglycerin patch from a patient's chest and wipe the area with a dry towel before defibrillation because those patches can ignite. You want to make sure that you remove that while you're wearing gloves. You don't want to get that what's inside that patch on you and create issues. If you need to shave the chest. That's going to help with pad placement. You need to determine the patient's NOI or MOI. Perform spinal immobilization if it's needed. Need to call for ALS assistance if you're in a tiered system with a patient cardiac arrest, and then also use that well-organized team approach for that. Pit crew team, right? Pit crew team when you're doing that. All right, so there's the AED algorithm here. Found on chapter 17, the 18th figure. So if you witness a patient's cardiac arrest, you got to begin CPR with the chest, compressions, and attach the AED as soon as possible. You see in your skills drills in 17.3 for use of an AED. Make sure you follow your local protocols for AED use. After the AED protocol is completed, one of the following things are going to be most likely. So if a pulse is regained, it's what we call ROSC, ROSC, return of spontaneous circulation, ROSC, ROSC. So no pulse. So what can also happen is no pulse, and the AED indicates that no shock is advised. And also, what can happen is no pulse, and the AED indicates that a shock is advised. If ALS is responding to the scene, we want to stay aware that you are and continue the sequence of shocks and CPR. If ALS is not responding to the scene and the protocols then agree, you can begin transport when one of the following occurs. So if the patient regains a pulse, 6 to 9 shocks are delivered or is directed by your local protocol, the machine gives 3 consecutive messages, so separated by 2 minutes of CPR. So if it does that, 3 consecutive messages separated by 2 minutes of CPR, that no shock is advised, or whatever you're directed by local protocol puts in there as well. So cardiac arrest during transport. If you are traveling to the hospital with an unconscious patient and the patient becomes pulseless, you need to stop the vehicle, begin CPR if the AED is not immediately ready. Call for ALS support or other available resources based on circumstances and local protocol. Analyze the rhythm, deliver 1 shock if it's indicated, and immediately resume CPR. Continue that resuscitation according to your local protocol. If you're en route with a conscious adult patient who is having chest pain and becomes unconscious, what you're going to do is you're going to check for a pulse, stop the vehicle. All right, if they become unconscious, check for a pulse, stop the vehicle, begin CPR if the AED is not immediately ready, analyze the rhythm, deliver 1 shock if it's indicated, and immediately resume CPR. Begin compressions and continue your resuscitation according to your local protocol, including transporting the patient. So from there, you want to coordinate with ALS personnel according to whatever your local protocol states. If you have an AED available, do not wait for paramedics to arrive. Notify ALS personnel as soon as possible after you recognize a cardiac arrest. Don't delay defibrillation. That's going to be said over and over again. When the paramedics arrive, inform them of your actions to that point, and then interact with them according to your local protocols. All right, so the management of return of spontaneous circulation. You're going to monitor. So if you get ROSC, or that return of spontaneous circulation, you're going to monitor for spontaneous respirations. You're going to provide oxygen via bag valve mask at 10 breaths a minute. You're going to maintain an oxygen saturation between 95 and 99% for these patients. You'll assess the patient's blood pressure as well. You'll see if the patient can follow simple commands. And then if ALS is not on scene or en route, you'll immediately begin transport to the closest appropriate hospital, depending on your local protocol. All right, so what we're going to do is we're going to take a quick 10-minute break, and then we're going to come back. We're going to do this practice patient assessment, and then we're going to break at the end of, or we're going to close the class out. So y'all figure out who wants to be a rock star on this patient assessment. 10 minutes, I'll be back, and we'll get that person ready to go, and we'll do this assessment. All right, 10 minutes, starting meow. All right, so who wants to be the first person, or who wants to be the victim tonight? Who's ready for that? Anybody? Y'all been doing great. Y'all gonna make me call on somebody. All right, I'm gonna pick on Dylan. Did you light up?
Yeah, I'll do it.
Awesome. Good to go. All right. All right, so you have a so the dispatch is gonna be car 51. We'll say car 51. I don't know if any of y'all ever watched Emergency or or anybody's old enough. I'm barely old enough for it, so car 51 needs you to respond to 123 Anywhere Street for a possible cardiac condition. Patient says that his chest is hurting. All right, let me know when you're en route.
All right, car 51 en route.
All right. All right, so going to the scene, you're thinking cardiac, so automatically you should be getting ready in your head what's going on. What's going to be the first thing you do as you're pulling up?
I'm going to do BSI, scene safe.
Okay.
And then once I'm going to don my appropriate PPE.
Okay. So always good to say is once you do that, yep, I'm going to put my appropriate PPE. They may ask you, what is your appropriate PPE? And you can say gloves and safety goggles, and that'll be fine. Then you come, you say, is my scene safe? So at that point, you're going to come walking up and you're going into the patient's home and you don't see any immediate hazards. All right, what's next?
So it looks like my scene is safe. So next thing is I'm going to determine the number of patients.
Okay. So first, before that, we're going to determine the mechanism of injury or nature of illness, right? So what is suspected of this? What are we suspecting could be an issue? They just said chest pain and what have you. So what are we suspecting at this point possible?
It could be cardiac arrest. It could be angina. There's a list of things with the chest.
Yep. So the patient is conscious right now. So we'll say possible myocardial infarction, possible heart attack, if worse comes to worse. All right, cool. All right. So yes, there is one patient. You said that determine the number of patients. All right. What's next?
Then I'm going to hit my ABCs.
Oh, remember, if we're going down the line, number of patients, one. And then we also look for additional resources. Now, given that it is a cardiac issue, are we going to consider ALS?
Yes, of course.
Absolutely. So, considering the nature of illness, we're going to let ALS, or we're going to have ALS come en route to back us up. All right. And then what's very next after you consider resources? Right before you get into primary assessment, there's one line there.
Consider transport.
Consider C-spine.
Consider
C-spine stabilization. So once we consider that stabilization, at this point, we're at the home office of the guy. He's sitting there in his chair. Does he look like he needs C-spine at this point?
No.
No. So we considered it. He doesn't need it. We're moving on. All right. Now we're getting into our primary assessment. So first, we want to make sure that we give what's our general impression of the patient. So what you see, so as you're walking in the room, you see a 55-year-old man. I said 45, didn't I? Or 55. So you see a 55-year-old man that's clutching his chest, and he appears to be pale and diaphoretic. Okay, so what is our general impression of this patient?
General impression is that he is low on oxygen, possible poor circulation.
So sick or not sick, right? So we're gonna say this patient is sick, right? Awesome. All right. So from there, this patient, when you walked in, he's looking at you. He's looking at you as you're walking in. He's waiting on you to start talking to him. So he's awaiting you, right? So at this point, what are we looking for in this patient next? So we went general impression. Now we're going to look at what?
Level of consciousness.
And since he looked at you as you're coming in and he's followed you along, what are we going to say his level of consciousness is?
Level A.
Right. So he's at this point he's alert. So we can do that. He does appear distressed. All right.
All right.
So as you come walking in, I'm distressed. I was like, I have severe chest pain and it's radiating to my left arm. All right, go ahead.
Would I be at the ABCs now?
Yep. You would.
Yes. Yeah. So airway, breathing, circulation. How's his breathing? Is it labored?
So his airway is patent. His breath sounds are clear bilaterally. And then his breathing is slightly rapid but adequate. So if it's slightly rapid but it's adequate, he's having that little bit of distress, but he's not unstable at this point. Looking at him, what did we talk about that we were going to put on this patient?
Non-rebreather.
So we can actually remember he's stable. So if he's stable and he's not showing signs or severe signs at this point, since it's stable, then we can administer that oxygen since he's talking to you.
Right. Nasal cannula.
Nasal cannula.
Yeah.
Remember at what rate we were going to do?
We do 2 liters per minute.
You can do 2 to 4. That'd be fine. Okay. All right. What's next? So that covered airway and breathing. So what's next?
We would check his circulation,
Okay.
check his pulse, his carotid, and his radial.
All right. So since he's conscious, we're just going to check his radial, right? Because checking a carotid on a conscious patient is a little awkward. So we're going to check his radial since he's conscious. If he was unconscious, we would then check his we would then check his carotid if he was unconscious. So you check his radial, and upon checking his radial, he is rapid and irregular. What else are we going to check with circulation? We're going to assess one more thing with circulation.
Blood pressure.
No, that's vital signs later on. But remember, in primary, it's real quick. So we're going to assess skin, right?
Skin color, yeah.
Yep. So his skin is pale, cool, and clammy. Okay, which is like sweaty or diaphoretic, right? Pale, cool, and diaphoretic, which is classic signs, right? Where our alarm should be hitting off pretty hard right now. All right, so what's the next thing? After we've done ABCs, what closes out our 15 minutes?
Our vital signs?
Nope, so our 15 minutes cuts off when we do what?
Transport.
Transport, awesome. So what type of transport do you feel like this is?
I would do primary.
Yep, so he's a high priority patient, awesome. Yep. And he's going to need transport with ALS support. Great job. So your 15 minutes is up there. So now your 15 minutes is up. You let that breath out. Whoever your evaluator is says, all right, 15 minutes now. What's next? At what phase are we at now? We did primary. Now we're in what phase?
Secondary reassessment.
Hold on. It'd help if I would keep up. Oops. So here's where we're at now, if you can see the screen.
History taking.
Yep. So we're in the history taking. And what are we doing with the history taking?
Just getting a general background. We find the OPQRST, the onset, all that.
Okay. All right. So let's go ahead and do the OPQRST. How would you want to do that?
Start with the onset. So how did this come about? What were you doing whenever this happened?
So it started about 30 minutes ago.
Okay, and what were you doing whenever this happened?
So I was just reading. I was reading at my home office, sitting here in my home office reading, not doing much of anything else.
Okay, and on a scale of 1 to 10, how would you describe the pain?
So on a scale of 1 to 10, it'd be a 9 out of a 10. If I were describing it, if you're the quality, it feels like a heavy weight is on my chest.
Okay. And is it radiating to any other parts of the body? I know you said to your right arm
So
earlier.
it's radiating to
Your
my left arm and
left
my
arm. So,
jaw. Yep, and my jaw.
all right. I'm blanking on the S.
All right, so
Uh,
that's severity. That's at a
Severity.
scale of 1 to 10. Yeah, that's
Okay.
scale of 1 to 10. So onset, about how long ago this start, and then P, provocation. Is there anything that makes it better or worse? And then yeah, I would say I was just reading when it started. And then quality, OPQ, quality. Can you describe to me the pain? And which we covered that was feels like a weight. And then R would be radiation, which would be radiating to the left arm and jaw. And then S would be on a scale of 1 to 10, 10 being the worst pain you ever felt in your life. How would you rate your pain? And I gave a 9 out of 10. And then next, the last one is what for OPQRST?
Time.
Yep. So it's been consistent since it started. So for the past 30 minutes, it's been a consistent pain. Right. And then from there, we can do any type of clarifying questions. So if that's pertinent negatives or what have you. So you'd be like, something to put would be like, or something to ask would be like, have you had any nausea or shortness of breath? And then I would answer, yes, I feel nauseous.
Okay. And
All
do you
right.
have a, oh, yeah, go ahead.
Nope, go ahead. So after OPQRST, you have one more mnemonic that we're going to cover.
Sample.
Yep. And so go ahead.
What signs and symptoms have you had that explain or that led you to call us?
So signs and symptoms, signs of what you see, the cool, pale, diaphoretic. You also with the heart rate, I feel really bad. I feel like I'm gonna die. I feel like I'm gonna die. I don't feel good at all. Just feel really sick, and I have this bad pressure in my chest. This feels like an elephant sitting on my chest.
Okay.
All
Are
right.
you allergic to any medications?
So no, I don't have any allergies to any medications.
Do you presently take any medications for any underlying conditions?
So I take aspirin and then I take a beta blocker as well.
Okay. Any past medical issues concerning your heart or any other respiratory or cardiovascular issues?
Yeah, so I've had angina in the past.
Okay. Did you take any medicine for angina in the past?
I mean, I've taken my usual my aspirin, my daily aspirin regimen, and my beta blockers, but that's the last medications that I've taken.
Okay. And what's the last thing that you had to eat and how long ago was that?
So I had a regular lunch meal, a sandwich, and a bottle of water about 3 hours ago.
All right. And any events leading up to this, prior to
Uh,
this, coming days, previous days?
nah, I was just reading at the house in my office when this started. So about 30 minutes ago while I was reading.
All right. I think that's it on the sample.
Yep, knocked it out. That was awesome. All right, what phase will we move into next?
Uh,
Hold
I
on,
would
let me.
say, yeah, the secondary assessment, the head to toe,
All right,
checking
so
for
is
any
this going
other.
to be a detailed or a focused assessment? Since this is a
Uh,
medical, we would more likely look at it as a what type of assessment?
as a focused,
Yep. So as a focused assessment.
right.
Okay. What do you think we're going to focus on, or what would you like to focus on?
I would probably palpate the neck area, I would oscillate the lung sounds,
Okay.
check blood pressure.
All right. So
and
let's do this. So cardiovascular wise, you already checked cardiovascular. I'm tachycardic. I'm irregular pulse. Have an elevated blood pressure. You're fixing to find out when you do the vitals. Uh, Neurologic, we already said that I was alert and oriented. Pearl on the pupils. My skin condition. This is where you kind of run back through. You're really focusing. Respiratory, clear on both sounds, or clear breath sounds, both sides. All right. So you did that. Mostly cardiovascular and respiratory would probably be your main ones, which is going to be the tachycardic, irregular pulse, elevated blood pressure, and then clear breath sounds. All right. So next we move into vital signs. What vital signs would you like to get?
Definitely blood pressure. We'll do the SpO2,
Okay.
the pulse and heart rate.
Okay. All right. So my
Probably the
initial.
respiration rate, I would say too. The
Go ahead.
respiration rate as well.
Yeah. All right. So my initial blood pressure is 180 over 110. My initial pulse is 110 and irregular. My initial respiratory rate and quality is going to be 20 and slightly rapid. Blood glucose, I really wouldn't say indicated at this point, but if you did get it, it's 110. And then my pulse ox is 96%. And if you did do capnography, because you got me hooked up, then my initial is going to be 35 millimeters of mercury right now. All right. So at this point, what are you going to do? Or what are you looking at?
My general field impression is that this patient is having a heart attack, and we're going to be preparing for transport.
Yep. So awesome. So my impression and your impression of this is acute myocardial infarction, or an AMI, right? All right. So so now your interventions. So what interventions would you like to get if your protocol says it's okay? So your protocol says that you can give nitroglycerin, you can assist with nitroglycerin, or you can give nitroglycerin and aspirin. So how would you like to do that?
I would assist the patient with their normal dose of aspirin, or I'm sorry, with nitroglycerin, as long as the blood pressure didn't drop too low.
Okay. All right. So you have the blood pressure of what was it?
180 over, I can't remember the decile.
110.
110.
Yep. So 180 over 110. So you would indicate that they could get nitroglycerin, right?
Mm-hmm.
All right. So you give them one nitroglycerin, and then after you do that, generally what I do is I say, all right, now on a scale of 1 to 10, 10 being, 1 being the least pain you ever felt in your life, 10 being the worst pain you ever felt in your life, how would you rate your pain? After about 3 to 5 minutes, that's when I would ask this while I'm taking their blood pressure. And at this rate, I would tell you that took my one nitro. I feel like it's down to a 6.
Okay.
Okay.
And what would be the blood pressure after the second assessment?
So his second set of vitals is a 160 over 95. Pulse is 100 and regular. His respirations are 18 and SpO2 is 98 because we have him on O2, right?
Right.
Okay. So if he still has a 6 of pain, what would we consider doing?
Possibly giving him a baby aspirin and then another round of nitro.
You already gave him the 324 milligrams of aspirin. So I would just give him another nitro. And
Okay.
it's so long as because his blood pressure is 160 over 95, so he can handle it. And you can do that so long as his blood pressure systolic blood pressure stays over 100. You can do that 3 times, right?
Mm-hmm.
So and then because our goal is 0 pain, right? Just until 3 times. Now, if you get to 3 doses per your protocol and he's at a 3, then when he gets to the hospital, they can carry that on, right? Besides that, and that's about that's a good 15, 20 minutes of ride along that you've been doing anyway. So if you're checking every 5 minutes, right? All right. So your reassessment for this patient, what would you say your reassessment of this patient is? How often?
I would say every 5 minutes.
Yep.
No, is it 5 minutes?
Yep. I would say 5 minutes. So for this patient, because he's even though he's starting to come down, he's still got a high blood pressure. His pulse is 100. He's starting to line out, but he still has that chest pain. So I would check every 5 minutes, and then from there, I would, if you have the ability to check the cardiac rhythm, you got ALS on scene, check the chest pain, just do kind of like a quick OPQRST, and then you would just reevaluate from there. All right, so you get to the hospital after doing all of this, and you have to give your verbal report to the nurse. What are you gonna say?
We have a 55-year-old male patient called in with chief complaint of chest pain. Upon arrival, he was sitting upright, he was conscious, alert. He has a history of angina. He appeared to be having a heart attack or myocardial infarction. We assisted with 3 rounds of nitro and also administered 325 milligrams of aspirin, monitored every 5 minutes. I believe that's it.
What was his vitals?
The last
Always give
vitals,
that instead of vitals. Go ahead.
the last vitals we have are 160 over, did you say 100?
95.
Over 95. Pulse rate was 100. Breathing rate was 20 beats per minute, or 20 breaths per minute, regular rhythm.
Okay. All right. Awesome. Great job. Fantastic. Knocked that one out the park. All right. Appreciate you, Dylan. That was perfect.
Yes, sir.
Right. Does anybody have any questions about anything that we went over with the lesson or with the patient assessment we just had? Okay. If not, then I'm going to go ahead. We're going to close out the class. Here is your class code. No. So if the patient had aspirin earlier, depending on how long ago it was, so you could still give the aspirin if he'd had it this morning or what have you. You could still give the aspirin later on. The time frame is kind of up to you between hours. If he took it, that's why I always ask, when did you take it? I took it this morning. Let's say it's 5 o'clock in the afternoon now. As you know, aspirin and what have you, we take those in 4 to 6 hour increments, right? So that's the way I look at that. If I wanted to give another low dose aspirin or the 324. Yes, and also treat for shock. Good job. Good job, Caleb. So treat for shock, cover that patient up. Perfect. Fantastic. Y'all are clicking right along. I like it. I like it. I like it. All right. Any other questions or suggestions or anything else? Fantastic, man. Y'all are hitting on all cylinders. That's awesome. All right. So tonight's class code is 1983, which was an awesome year for certain babies to be born. They're just the greatest babies in the world were born in 1983. I'm not biased for that. Not biased in that in any way. All right, so what happened in 1983, other than the fact that awesome people were born? So in 1983, the American College of Emergency Physicians, or the ACEP, established the EMS Fellowship Program to enhance education and training for EMS physicians. So the establishment of the EMS Fellowship Program by the ACEP, it aimed to advance the education and training of the physicians in the field of emergency medical services. So EMS fellowships provide specialized training in EMS system design, disaster management, pre-hospital care, and administrative leadership. So these programs equip physicians with the skills and the knowledge to contribute to the improvement of EMS systems and patient care. So that happened in 1983. That's your class code for tonight. That's what you're going to put in your stuff. I done started some stuff about the years. 2002. That's when I graduated high school. So 2002. So on items coming up due, Saturday, August 19th, 2023. It's going to be due by 11:59. At 11:59, it shuts out. Won't have a chance to do it again. We're going to make sure that we do chapter 18. What did I do here? I'm sorry. Today we're chapter 17. Sorry. So that should be 17 and then chapter 18. So 17 and 18, not 19. That's my bad. I accidentally messed that up. I'll fix it at some other date. But so chapter 17 and 18, don't even pay attention to this part here. Here, let's just do this. There, don't even pay attention. So make sure you do chapter 17, cardiac emergencies, and then chapter 18, neurologic emergencies. Make sure you do that by Saturday, okay? And then coming up next, which will be Thursday. So coming up, we're going to be talking about neurologic emergencies, chapter 18. So everybody go ahead and read that, study that, and then we get back. That way y'all knock this out again. Fantastic job with the patient assessment today. I think we're really starting to get a hang of it. As we start to get better at it, then I'm going to start giving less and less till y'all are just knocking it out on your own, right? So, like we said, chapter 17 and 18 will be accomplished or need to be accomplished by Saturday, August 19th. And then make sure you go ahead and study chapter 18, neurologic emergencies, for Thursday. All right. So do we have any questions about what we went over today? No, chapter 19, let's take that out. I'm sorry, I was just reading here. So chapter 17 and 18 will be due on Saturday. 19 is not going to be due. That's my fault. I screwed that up. All right. So if nobody has any questions about what we went over tonight, I'm going to go ahead and stop recording. If you don't have any more questions for me after I stop recording, then feel free to go ahead and log off. Thank y'all for coming out, and I really appreciate seeing y'all. Thank y'all.